Hello everyone. Now we will discuss about the history, physical examination, and the management part of pulmonary artery hypertension. So they are telling like except for mild breathlessness, pulmonary artery hypertension is generally asymptomatic until it got severe. So non-specific symptoms and under recognition of this disease leads to leads to significant delay between the onset of symptoms and diagnosis of pulmonary artery hypertension. So dyspnea on exertion is the most common presenting complaint. So dyspnea on exertion is the most common presenting complaint of PH. Hoarseness could be there due to paralysis of left recurrent laryngeal nerve because it got trapped between aorta and dilated left pulmonary artery. So we call it alternate syndrome. So hoarseness will be there because of paralysis of left recurrent laryngeal nerve got trapped in between aorta and dilated left pulmonary artery. So this is known as alternate syndrome. Then if the right ventricle should fail, lower extremity swelling is very common in these patients and abdominal signs will be there and symptoms including a sensation of bloating. So bloating sensation is very common in case of pulmonary artery hypertension patients. So they are telling early satiety will be there, tender hepatomegaly will be there, ascites will be there, and abdominal pain could be there. Symptoms of right ventricular failure and the presence of syncopal events are associated with worse prognosis. If a patient is having these signs, symptoms of right ventricular failure, then this is associated with worse prognosis of this patient. Then they are telling an important hint to the presence of pulmonary hypertension is history of long-standing dyspnea that has not responded to treatment for other common disorders. So we have like given every kind of treatment, but patient is not responding, then we should have suspicion for like pulmonary artery hypertension. These include symptoms of collagen vascular disease, dysphagia, skin or joint changes could be there, Raynaud phenomena could be there, sleep apnea could be there, like witnessed apneic event, daytime hypersomnolence, history of risk for thromboembolism could be there, HIV infection, liver disease, anorectic agent use, history could be there. So now we'll come to like what are the presenting symptom which lead to PH. So like most common presenting symptom is dyspnea on exertion, which is present in 86% of the patient. Then comes fatigue. Fatigue is present in 27% of the patient. Then edema could be there because of right heart failure in 21% of the patient. Then pre-syncope or syncopal event could be there. And then come dizziness or lightheadedness. After that, abdominal distension, chest pain, discomfort, cough, dyspnea at rest, palpitation. These are the common feature of PH. But like the most common presenting feature is dyspnea on exertion and fatigue. Now they are telling about the World Health Organization function classification of the patient with PH. So there are four classes. First class is like patient with pulmonary hypertension, but without resulting limitation of physical activity. There is no uh, limitation of physical activity. Patient like can do ordinary physical activity, and there is no dyspnea, fatigue, chest pain, or syncope. In class two, like patient with pulmonary hypertension resulting in slight limitation of physical activity. They are comfortable at rest, but on ordinary physical activity causes undue dyspnea or fatigue, chest pain, or near syncope. In class 3, patient with pulmonary hypertension resulting in marked limitation of physical activity. They are comfortable at rest. Less than ordinary activities can cause dyspnea or fatigue, chest pain, or near syncope. And in class 4, patient with pulmonary hypertension with inability to carry out any physical activity. They are not able to carry out any physical activity without symptoms. These patients manifest sign of right heart failure. Dyspnea and fatigue may even present at rest. Discomfort is increased by any physical activity. So this is the X-ray. This right-sided X-ray is of patient of pulmonary artery hypertension. You can see the enlargement of cardiac slough has been occurred in 30-year-old male, which is associated with dyspnea. And here you can see like this is a chest X-ray of a normal patient. Like this patient before 14 months like was like this, and after 14 months of getting PH, he was like this. So now we'll come to physical examination finding in pulmonary hypertension patients. So there are signs. First sign is like increased pulmonary component of S2 audible at apex in over 90% of the patient. So increased pulmonary component of S2 will be there. It will be because of high pulmonary pressure increases force of pulmonary valve closure, as we know. Then there will be early systolic click will be there, mid systolic ejection fraction will be there, ejection murmur will be there, left parasternal lift will be there, right ventricular S4 sound will be there, or increased jugular A wave will be there. Then comes like physical signs that suggest moderate to severe PH. So these like first are there are like sign of moderate to severe PH, which are like hollow systolic murmur that increases with inspiration, tricuspid regurgitation. There will be increased jugular V waves, pulsatile lever will be there, diastolic murmur will be there, hepatojugular reflex will be there. So these upper four signs are because of tricuspid regurgitation, while this diastolic murmur will be because of pulmonary regurgitation, and hepatojugular reflex will be there because of high central venous pressure. Then comes advanced PH with right ventricular failure. So here we can see right ventricular S3 will be there, distension of jugular vein, hepatomegaly, peripheral edema, ascites, low BP, diminished pulse pressure, and cool extremities will be there. Then comes physical signs that suggest possible underlying cause of associated of PH. So there will be like as they are telling, there will be like central cyanosis, clubbing, cardiac systolic murmur, diastolic murmur, opening synapse or gallop will be there, crackles, dullness or decreased breath sound, crackles, accessory muscle use, wheezing, protected expiration, protected cough will be there. So they are telling like these are because of pulmonary parenchymal disease. Then comes obesity, kyphoscoliosis, enlarged tonsil, narrowed pharyngeal opening, macroglosia will be there, uh, which can lead to disordered ventilation and sleep apnea. And they are telling sclerodatile arthritis, telangiectasia, Raynaud phenomena, or RAS will be because of connective tissue disorder. Peripheral venous insufficiency or obstruction will be because of possible venous thrombosis. Venous stasis ulcer will be because of possible sickle cell disease. Pulmonary vascular pruritus will be there because of chronic thromboembolic pulmonary hypertension. Splenomegaly, spider angiomata, Palmer erythema, icterus, caput meadows ascites. These all conditions will be because of portal hypertension. Then they are telling about the evaluation of the patient with pulmonary hypertension. So like for detection of pulmonary hypertension, we should take detailed history and do physical examination. Then ECG should be we should do ECG, chest radiograph, and 2D echo. So like history and physical examination are done to for suspicion of pulmonary hypertension and to rule out the what is the possible cause and what is possibly it is associated with. And ECG for to like exclude other causes of cardiopulmonary symptoms, and like 2D code to evaluate the presence of pulmonary hypertension, assess chamber size, function, valvular abnormalities, and like to study evaluate possible something is there or not. Then like essential testing, what are the essential tests? So they are telling PFT should be we should do PFT, overnight oximetry, lung ventilation perfusion scan should be there, blood serology we should do. In blood serology, CBC, liver function, renal function, HIV, ANA, antiphospholipid antibodies. After that, oxygen desaturation study, 6-minute walk test, right cardiac catheterization should be done. And there are contingent testing should be are there that we can perform like transesophageal 2D echo, like echocardiogram, computed CT of chest, polysomnography, pulmonary angiography, BNP, clotting studies, genetic testing, and lung biopsy. These are also helpful in the diagnosis of pulmonary hypertension. Then comes the requirement for the diagnosis of pulmonary artery hypertension. So they are required testing, and they what are the required testing? So they are telling like cardiac catheterization should be done, and in cardiac catheterization, a mean pulmonary artery pressure should be more than 20 mm Hg. A mean pulmonary artery pressure should be more than 20 mm Hg. Pulmonary artery wedge pressure or left ventricular and diastolic pressure. Left ventricular and diastolic pressure or pulmonary artery wedge pressure should be less than 15 mm Hg. Very, very important. And they are telling pulmonary vascular resistance should be more than 3 Wood units. Very, very important. And like what is the rationale? So they are telling this cardiac catheterization confirm the presence of pulmonary hypertension and exclude left heart disease, because this like pulmonary capillary wedge pressure used to get increased in case of left ventricular involvement, left heart disease. But it is because of like this is an isolated pulmonary hypertension is an isolated disease. That's why there is reduced pulmonary capillary wedge pressure. So we should perform PFT, chest imaging, and there is no evidence of any lung disease more than mild lung disease. And they are telling ventilation perfusion scan without evidence of unmatched perfusion defect should be there to rule out chronic thromboembolism and like okay, huh. After that, we comes to the therapy for pulmonary arterial hypertension. So first thing come which is like exercise. Exercise, they are telling like what is the importance of exercise. So they are telling, regardless of the cause, patient with pulmonary hypertension and core pulmonary should be encouraged to maintain an active lifestyle as possible. So exercise is not contraindicated in every patient. In initial stages, patients should be encouraged to maintain an active lifestyle as possible. So now they are telling patient to minimize exertion or fear for further raising pulmonary pressure generally result only in deconditioning of the muscles and increase in fatigue and breathlessness when activity is attempted. So we should not counsel this to the patient. And they are telling regular steady aerobic exercise should be encouraged and is often best initiated under guidance of pulmonary and cardiac rehabilitation program. So they should be monitored. And indeed, randomized trial of exercise rehabilitation in patients with pulmonary artery hypertension or CTEPH have demonstrated not only the safety of exercise in these patients but improvements in exercise capacity and greater than the observed randomized control trial of currently available in pharmacological treatment for PH. So they are telling exercise is a good thing for the patient of PH, but importantly, activities that causes patient to experience lightheaded or syncope should be avoided. So this thing we should remember, if patient is feeling lightheadedness or syncopal episode, then we should those activities are including hot showers or bath or bending over to lift heavy object. We should Patient should not bend over to lift heavy weight, and he should not take this hot shower. So hot shower and bending over to lift heavy objects should not be done because these exercise can lead to syncopal episode. So this is exercise. After that comes oxygen therapy and immunization. Patient with pulmonary hypertension should avoid acute hypoxia. Hypoxic pulmonary vasoconstriction will add to burden on the right ventricle, and oxygen relieve hypoxic pulmonary vasoconstriction, thus decreasing vascular resistance and improving cardiac output. So oxygen is a good thing. It also lessens renal vasoconstriction, improve urinary sodium excretion, and decrease tissue hypoxia by improving oxygen delivery. So measurement of arterial oxyhemoglobin saturation should be performed at rest, with exertion and with sleep. So in three conditions we should check oxygen saturation. Level of arterial oxygen saturation below 90%. So this is the criteria for oxygen desaturation. If it is less than 90%, then we should give supplemental oxygen only below 90% saturation. Now they are telling the maintenance of adequate oxygen saturation may be difficult in patients with severe pulmonary hypertension in whom patent foramen ovale allows right to left shunting. So it could be difficult in these patients. Now they are telling air travel is particular concern because of threat of hypoxic pulmonary vasoconstriction. So if patient is taking a flight, then it could be concerned. So now they are telling immunization against influenza and pneumococcal pneumonia are important preventive measure in patient with these pulmonary hypertension and core pulmonary. And influenza vaccination should be done uh, like uh, annually. Every year it should be done. And 23-valent polysaccharide pneumococcal vaccine and 13-valent pneumococcal protein conjugate vaccine should be given as per protocols. Now comes fluid management and diuretics and digoxin. So careful attention to avoid fluid overload is the central management part of central management for right heart dysfunction of any cause. Patient must be educated for dietary habits, and they should restrict sodium intake. Very, very important. They should restrict sodium intake because if sodium retention will be there, then fluid retention will be there because fluid used to be there with sodium. So they are telling they should restrict sodium intake to decrease fluid retention and development of right heart failure. Patients should weight themselves daily. Daily they should do their weight to check is there any fluid retention or not, so that it can be reversed before progressive right ventricular overload will be there and result in failure. That may be then be more difficult to reverse and require inpatient treatment. So yeah, they should do daily weighting and restrict the sodium. Management of right heart failure relies heavily on diuretic therapy. Spironolactone is often used to manage mild fluid retention. It may also have beneficial effect in heart failure by modulating neurohormones. Loop diuretics are often required to prevent more significant fluid retention in right heart failure. Indeed, high dosage and combination of diuretics are often required to maintain appropriate fluid balance but must be used cautiously to avoid electrolyte imbalance and volume depletion. So we should like be little bit cautious when we are giving these loop diuretics. Now we'll come to digoxin. It is unclear whether cardiac glycoside should play a role in treating right heart failure or not. Intravenous administration of 1 milligram of digoxin resulted in modest increase in cardiac output after 2 hours, but longer term data is not available. Now we'll come to anticoagulants. Benefit on the basis of autopsy studies revealing in situ thrombosis in both venous and arterial vessels without evidence of embolic source is significant proportion of the pH. It is also justified on the basis of increased risk of venous thromboembolism disease in patients with severe heart failure and immobility. So that's why we should give anticoagulant as per these data. Like there are like more chances of formation of thrombosis in these pulmonary vessels. Firm guidance regarding the use of oral anticoagulant therapy in PAH is lacking, and the practice is shifting with time. The evidence remain weak but favor the use of IPH. So, in case of idiopathic pulmonary hypertension, there is the beneficial role of this anticoagulant therapy, but it is not like much helpful in other cases of pulmonary artery hypertension. So, and like there, we don't know the role of newer non-warfarin oral anticoagulants like rivaroxaban, dabigatran, the role of these anticoagulants we don't know. Now comes PAH risk assessment 2015 ESC or ERS guidelines. So they are like multiple factors, like they are telling these are determinants of prognosis, estimated 1 year mortality. So they tell about estimated 1 year mortality. So are there clinical signs of right heart failure or not? Progression of symptoms, we will see syncope, WHO functional class as we have read earlier, 6 minute walk distance, cardiopulmonary exercise testing, we will see anti-proBNP plasma level, we will see 2D co finding, we will see, and hemodynamics we will see. So in these, like we can divide in three categories. Like first category is of low risk patients, like less than 5% chances. Then intermediate risk, which have risk for 5 to 10%, and high risk means like more than 10% risk. So like if clinical sign of right heart failure either absent, then present. Progression of symptoms no, slow, rapid. Syncope no, occasional syncope or repeated syncope episodes are there. WHO functional class 1, 2, 3 or 4. Then comes 6 minute walk distance. Is it more than 450 meter? Is it between 165 to 440, or it is more less than 165? Then comes cardiopulmonary exercise testing. Peak volume of oxygen more than 15 ventilatory oxygen volume more than 50 ml per minute per kg, or it is like 11 to 15 ml, or it is less than 11. Then comes BNP level. BNP level less than 50, 50 to 300, more than 300, or anti-pro-BNP level less than 300 nanogram per liter, or between 300 to 1400 nanogram per liter, or it is more than 1400 nanogram per liter. Then comes right at in 2D code, there comes right atrial area less than 18 centimeter square, or no, with no pericardial effusion. Then comes right atrial area more than 18 to 26 centimeter square and no or minimal pericardial effusion. Then comes right atrial area more than 26, so less than 18, 18 to 26 or more than 26 with pericardial effusion. Then comes hemodynamics. They are telling right atrial pressure less than 8 mm of Hg, then 8 to 14 mm of Hg, then more than 14 mm of Hg pressure is there. Then we'll come to like there is a risk score which is known as Reveal 2.0 updated pH risk score. It contains a lot of factors like WHO group, then demographics, then comorbidities, then NIHA, WHO functional class, then vital signs, all cause hospitalization less than 6 months, 6 minute walk test, BNP, electrocardiogram, pulmonary function test, and right heart catheterization. Now we'll come to contraception and pregnancy. Pregnancy in women with IPH is associated with high maternal mortality, very, very important. In order to 30 to 50% cases, in 30 to 15% cases, mother can die. So expert consensus is that pregnancy should be avoided. Like as much as possible, we should avoid it. And early termination of is recommended on account of high maternal mortality. Effective contraception should be ensured in case of hormonal contraception. because anticoagulation is advised to reduce the risk of venous thromboembolism. So they are telling with hormonal contraception, we should also advise anticoagulants because these hormonal contraception leads to venous thromboembolism. So to avoid that, we should give anticoagulant therapy also. They are telling an attack can be precipitated by pain, nausea, vomiting, straining. Induction of anesthesia and intubation may be particularly troublesome time. The combination of bradycardia and systemic vasodilation can lead to pre precipitous drop in systemic blood pressure, and atropine or similar agents should be kept at hand during invasive procedures. So here we can see a ECG with patient with IPH. Here you can see this is the like bradycardia, like heart rate is like this is very slow, and like they are telling prolongation of atrioventricular conduction and progress to atrioventricular dissociation while patient was on bedpan, which is associated with syncope. Now we'll come to pharmacotherapy. In this, like first therapy is calcium channel blocker. So they are telling, although not approved for PAH, calcium channel blockers are still have therapeutic role in rare onset of PAH patient, which are demonstrated acute pulmonary vasoreactive. So the patient who are vasoreactive, in them calcium channel blocker are the best treatment. So they are telling calcium channel blocker diminish vascular tone by preventing an increase in cytosolic. They prevent increase in cytosolic calcium concentration through inhibition and both influx of extracellular calcium and release of calcium from intracellular space. So like these used to block both of these like conditions. Now comes to like long-term prognosis. It's good for PH patients who respond acutely to the administration of short-acting pulmonary vasodilators, such as inhaled nitric oxide, intravenous adenosine, or intravenous epoprostenol, and are then treated subsequently with calcium channel. So like before that, we have to do vasoreactivity test. That in one study, survival rate of acutely vasoreactive patient treated chronically with oral calcium antagonist was maintained at 94% when measured at 1, 3, and 5 years of after like getting PH. Unfortunately, relatively low few patients demonstrated acute vasoreactivity. So they are telling like only 10% of the patients, according to recent estimates, only 10% patient used to show acute vasoreactivity, and only in these patients calcium channel blockers are sufficient, like are good, and those of only half experience a sustained clinical response. So in like 10%, only like 50% means like total 5% patients are like having like good response for calcium channel blocker. Oral calcium channel blockers could not be used as vasodilator therapy in absence of documented uh, acute vasoreactivity. Like in only in the case of acute vasoreactivity, we can give calcium channel blocker. The current definition of positive acute, what is like acute vasoreactive response? So this is like decrease in mean pulmonary artery pressure by more than 10 mm of Hg to absolute mean pulmonary artery pressure less than 14 mm of 40 mm of Hg with an unchanged or increased cardiac output. Only then we will think like he is responding for calcium channel blocker. So decrease in MPAP by more than 10 mmHg and absolute MPAP less than 40 mmHg. Those failing to demonstrate acute vasoreactivity not only fail to benefit from calcium channel blocker but are also prone to adverse effects. And like what are the adverse effects? They are like systemic hypotension, decreased cardiac output negative because of negative inotropic effect, arrhythmia could be there, salt and water retention, syncope, death could be there. So these are the side effects of this calcium channel blocker. Acute vasodilator testing is required to determine whether a clinical trial of calcium channel blocker therapy is appropriate, and side effects include systemic hypotension, peripheral edema, and gingival hypertrophy could be there. So peripheral edema, hypotension, and gingival hypertrophy are the side effect of calcium channel blockers. Now comes prostacyclin analogs. The prostacyclin analog like epoprostenol was the first FDA approved therapy for the treatment of PAH. To this day, IV prostacyclin therapy are the most potent management for PAH patients. What IV prostacyclin like epoprostenol. Prostacyclin is powerful vasodilator, both pulmonary and systemic, as well as an inhibitor of smooth muscle cell proliferation and platelet aggregation. It is a product of arachidonic acid metabolism, and it used to increase intracellular CAMP. So prostacyclin like epoprostenol used to increase the level of CAMP. It's a major source. So they are telling its major source is vascular endothelial cells, and the deficiency are noted in patients with PH, although it is not clear whether these lower levels represent a cause or they are effect of PH. Now they are telling synthetic prostacyclin analog are available for long-term treatment of PH, including formulations administered by continuous intravenous infusion, like epoprostenol, treprostinol. Subcutaneous infusion we can give like treprostinol like we can give with subcutaneous infusion, and inhalational like treprostinil and eloprost. So the treprostinil can be given by every route, but the iloprost is given only by inhalational route, and the epoprostenol is given by mainly IV route. Now they are telling, in addition, Selexipag is an oral specific IP receptor and agonist. This is like receptor agonist that selectively target the prostacyclin receptor. So Selexipag is an important specific IP receptor agonist. Now comes parenteral prostanoid therapy require a capable and compliant patient to safe administration. They are telling like IV, they are telling about IV epoprostenol and treprostinol. Epoprostenol therapy is initiated at 2 nanogram per kg per minute and gradually increased in 0.5 to 1 nanogram per kg per minute increment at intervals dictated by the patient's side effect and response. So this is like epoprostenol. Now comes treprostinil is initiated at 1.25 nanogram per kg per minute and similarly increased and dictated by clinical response, typically an increment of 1.25 nanogram per kg per minute. The risk of interrupted treprostinil infusion is somewhat lower on account of its longer life. So treprostinil having a longer half-life. The originally available formulation of epoprostenol is unstable at room temperature. So they are telling like epoprostenol is unstable at room temperature and must be mixed daily and kept cool with ice packs. So this is like problem with epoprostenol because it used to be unstable at room temperature. Like treprostinil, subsequently approved formulation of epoprostenol has greater stability at room temperature and not require cautious cooling with ice packs. So they are telling now like good approved formulation of epoprostenol are available, which are stable at room temperature and not require continuous cooling with ice packs. And experience suggests that higher dosage of treprostinil is required than epoprostenol to maintain an improvement in symptoms. Furthermore, observation is required to establish whether survival is similarly improved with treprostinil as with epoprostenol. Experience and established duration of benefit is greatest with epoprostenol infusion. So now like we are giving epoprostenol infusion and it remains the important for severe PH and benchmark against the other therapy and are often compared. So till date like epoprostenol are the best thing, best IV therapy for severe PH patients. Very, very important. Now comes subcutaneous prostanoid therapy. So they are telling in subcutaneous prostanoid therapy, treprostinil is available as we know. Uh, it is approved for subcutaneous administration prior to IV use. The major advantage of subcutaneous treprostinil is because it avoids the intravenous catheter, obviously, and associated risk of life-threatening bacterial infection could be there or when bacteremia could be there. The major drawback of subcutaneous treprostinil is like it can be associated with significant incidence of troublesome infusion site pain. So like they are telling like pain could be there. So like pain is the important concern with subcutaneous treprostinil. Now they are telling like management strategy to reduce the occurrence and severity of pain have been reported, including like we used to put dry catheter insertion with delayed infusion of medication, less frequent site rotation, and application of topical analgesics. We can use topical analgesics and anti-inflammatory agents to reduce the pain in case of subcutaneous administration of treprostinil. Another relative disadvantage is slow rate of dosage titration, obviously compared with IV therapy, making it less attractive. It is like less attractive for severely ill patient for rapid response. In selective patients, however, subcutaneous treprostinil has proved to be effective therapy and has allowed for avoidance of risk and inconvenience associated with intravenous therapy. So they are telling like IV therapy is the best for case of severe PH, but in selected patient, we can give in whom like there is high risk of bacteremia, we can use subcutaneous treprostinil also. Now comes inhalational prostanoid therapy. So iloprost and treprostinil is there. Iloprost is an inhaled prostacyclin analog. As we know, treprostinil is also available for inhalation therapy. In addition to the late for need of invasive administration, inhaled therapy are easier to initiate. Very important. But frequent dosing is like a very big concern with inhalational therapy. because we used to give like 4 times daily of treprostinil and 6 to 9 times per day of iloprost, and compliance may be a challenge. In addition, as the hemodynamic effect waned prior to each administration, whether patient received the same benefit as a continuously infused prostanoid therapy, it is not clear yet. So it is unclear, like it is similarly effective with IV therapy. So now they are telling iloprost inhalational therapy is initiated at the dose of 2.5 microgram and increased till 5 microgram with subsequent dose if tolerated. So this is the dose of iloprost. And treprostinil is started at 18 microgram, like 3 breaths 4 times a daily, 4 times per day, with dose increase suggested every 1 to 2 weeks to a maximum and targeted dose of 54 microgram, which is equal to 9 breath 4 times 9 breaths, and it is given as 4 times daily. Inhaled prostanoid are each administered with drug-specific portal delivery devices. What are the side effects of prostanoids? They are like headache, nausea, diarrhea, flushing, jaw discomfort, systemic hypotension, syncope can be there, although they have not associated with further clinical deterioration in clinical trials. Now comes like oral prostanoid and prostacyclin therapy. An orally active prostacyclin analog like Beraprost appears to be result in non-sustained improvement in exercise capacity. So this is not like that good. The primary endpoint of the 6 meter walk distance noted treatment effect of 23 meter in patient receiving oral treprostinil. The most common side effects are headache, nausea, diarrhea, jaw pain. The subsequently completed Freedom 5 study reported benefit of oral treprostinil, reducing risk of clinical worsening when added with pH background monotherapy. They are telling like we have like did a study with monotherapy, but they are not like that effective. Unlike in the prior freedom study, oral treprostinil was administered 3 times daily instead of twice daily, but that was having like similar response. So yeah, it is helpful, but it is helpful in polytherapy more than monotherapy when we used to give like different category of drugs together. Now comes IP receptor antagonist, agonist. IP receptor agonist. The most recently approved therapy is IP receptor agonist, which is known as selexipag. Selexipag. Selexipag is an orally administered non-prostanoid IP receptor agonist. So this is the largest PH clinical trial till the date. So, and the name of this we will tell later. The current consensus opinion is that oral selexipag should not be initiated as replacement or parenteral prostanoid therapy, or in high-risk PH patient who needs the parenteral therapy. And the common side effects are of selexipag are headache, diarrhea, nausea, and jaw pain. Now comes endothelial receptor antagonist. Endothelial receptor antagonist 1, ET1, is a member of endothelin family of peptides secreted by endothelial cells that promote vasoconstriction and proliferation of vascular smooth muscle cells. ET1 is overexpressed in the vasculature of patient with PAH, and antagonist of its interaction with receptor ETA, ETB have been developed for oral use. So antagonist of endothelin receptor, sorry, are like very good, helpful in case of PH. So there are three these drugs. First drug is bosentan. Bosentan is dual endothelin A and B antagonist that improve hemodynamics and exercise capacity. Then comes embrisantan. Embrisantan is selective ETA antagonist. Bosentan was ETA and ETB antagonist. Embrisantan is ETA selective antagonist. So like they are telling side effect is peripheral edema, anemia, nasal congestion. And these like they are telling endothelin receptor antagonists are teratogenic drugs, and like in case of contraception, pregnancy, we should avoid them. Then third drug comes, which is known as the third and most recently approved endothelin receptor antagonist, dual ETA and ETB antagonist, macitentan. So macitentan and bosentan both are ETA and ETB antagonist, and like embrisantan is only ETA selective antagonist. Very, very important. And they are telling treatment benefit with macitentan 10 milligram daily were driven mainly by lower rate of disease progression and PH related hospitalization. The approval of macitentan was based on the first event driven randomized control study in PH, Seraphin. Seraphin was the largest and longest PH trial till the date for PH. So Serafin was the largest and longest PH trial till the date for PH. So we should know that this study was done for macitentan, for the use of macitentan. Now comes phosphodiesterase 5 inhibitors. Decreased level of nitric oxide mediated which lead to vasodilation, because nitric oxide used to lead to like vasodilation. So decrease of their level will lead to increase growth in patient with PH, lead to increase its effect therapeutically in order to promote improvement in microvascular remodeling. Nitric oxide act through the second messenger, which is CGMP, which is metabolized in the lung predominantly by phosphodiesterase type 5. Very important. So phosphodiesterase 5 is very important enzyme which used to metabolize CGMP. A specific inhibitor of phosphodiesterase type 5 can promote acutely pulmonary vasodilation and reduce the degradation of CGMP. So we need CGMP and NO. So if CGMP will be more, and we can increase this by inhibiting phosphodiesterase type 5. If CGMP will be more, then there will be more vasodilation. So they are telling the FDA approved dosage for treatment of PH is 20 milligram by mouth 3 times a daily. So this is the dose of sildenafil. And the longer acting phosphodiesterase type 5 inhibitor is tadalafil. Tadalafil is the dose of tadalafil is 20 to 40 milligram daily. Common side effect of phosphodiesterase type 5 inhibitor used to treat PH are headache. These are like headache and like flushing, diarrhea, epistaxis, and myalgia. These are the common side effect of these things. And systemic hypotension also occurred, particularly with concomitant use of nitrate. So they are telling very, very important thing that combination should be avoided. What combination? So they are telling that nitric oxide, sorry, nitrate and these phosphodiesterase inhibitors should be avoided. Very, very important because they can lead to hypotension. Very, very important. Now comes soluble guanylate cyclase stimulator. Soluble guanylate cyclase stimulator is like riociguat. Riociguat is very important. It is like orally administered, and like it used to increase CGMP, and like these used to act differently than phosphodiesterase type 5 inhibitors. Riociguat can work either in conjunction with endogenous nitric oxide or in absence of nitric oxide to produce CGMP. And riociguat has demonstrated safety and benefit both in patients with PH and those with inoperable CTEPH. So riociguat is very important drug. Before that, we have studied tadalafil and sildenafil. Before that, we have studied these macitentan, ambrisentan, and bosentan. And the side effect of this soluble guanylate cyclase stimulator is headache in 20% or 27% of patients, dyspepsia, peripheral edema. Now comes combination pharmacotherapy. Combination therapy is now standard treatment for PH. The first major signal using in combination therapy in PH came from PACES study. This was the first study to suggest that combining therapy may confer a survival benefit over monotherapy. So these combined therapy is like much way better. So evidence for upfront combination therapy came from ambition study. Ambition study like combination group was superior to monotherapy in reduction of anti-proBNP. Satisfactory clinical response was there. So they are telling like result of ambition and PACES are now reflected in current treatment guideline for PH. And they are telling exception of using monotherapy. There are like few things where we should use monotherapies. So what are those conditions? They are telling acutely reactive PH patient benefits from calcium channel blocker monotherapy, and existing PH patient who are maintaining low risk assessment status and continued benefit from monotherapy. In newly diagnosed PH patient, we should with comorbidities, and then we should give monotherapy only, and we should avoid combination therapy. So this was the result of ambition study. They are telling large event driven studies with macitentan was Serafin, for Selexipag was Grifone, and for oral treprostinil was Freedom 5. Freedom 5 have proved this thing. Now comes non-pharmacological intervention for pulmonary artery hypertension patients. They are telling lung transplantation remain an important consideration for some patients with PH whose disease fails to respond adequately to medical therapy. They are telling PH patients who are deteriorating despite optimal medical therapy and who have cardiac index less than 1.8 liter per minute per meter square, or right atrial pressure is more than 15 mm, may qualify for lung allocation score exception. So these are the donors who can give this thing like sorry, these are the patients who can take this like lung transplantation. Now comes balloon dilatation arterioseptostomy has been performed in palliative measures as well as bridge to lung transplantation in some patients with severe PH and symptoms refractory to other therapies. So we can bridge it with lung transplantation. At the expense of worsening of systemic oxygenation, the creation of right to left shunt at atrial level can help offload the struggling right ventricle. So it can reduce the volume in right ventricle by shifting the blood from right atrium to left atrium and improve cardiac output and symptoms in carefully selected patient with PH. Right atrial pressure greater than 20 mmHg prior to balloon dilatation arterial septostomy has been associated with tenfold increase in arterial in mortality and considered contraindicated. So they are telling if right atrial pressure is more than 20, then it is a contraindication. Very, very important. So this this more than 20 mmHg pressure, very important in right atrium, is contraindication for this balloon dilatation arterial septostomy. Very, very important. Now they are telling pulmonary artery denervation. There is another terminology which is known as pulmonary artery denervation. Applies the concept for renal denervation as means of potentially modulating vascular tone to pulmonary circulation. Both radio frequency ablation can be done or intravascular ultrasound based techniques can be used. And before that, like there are no data available for this pulmonary artery denervation, so it needs more data. Now we'll come like what is the final chart for the treatment part. They are telling one patient come to us, which is the newly diagnosed patient with PH. So like how what should we do? We should first confirm this PH by expert center, and we should tell him about the general measures and supportive therapy. Then we should do acute vasoreactivity test, very important, in case of idiopathic pulmonary artery hypertension or HPH or DPH only. In them, if he is vasoreactive, then we should start calcium channel blocker. Very, very important. As we know, 5%, like 10% patient used to be vasoreactive, and out of them only like out of them only 50% used to respond. So these are like calcium channel blockers. Then if they are not vasoreactive, they are non-vasoreactives, then we should go for like we should check if he is lower intermediate risk or high risk patient, as we have like shown in the previously in the risk assessment score. So if he comes in uh, high risk, then we should start initial combination including IV PCA. IV therapy should be started. And if he belongs to lower intermediate risk, then residual role of initial monotherapy, there is not much role, but we should start initial oral combination. So initial oral combination is good for those lower intermediate risk patients. Then after 3 to 6 months of treatment, we should assess again. If he belongs to low risk, then we should like follow up him every 3 to 6 months. If he belongs to intermediate or high risk, then we should give triple sequential combination of drugs. After again after like 3 to 6 months of treatment, we should check if he is responding or not. And after 3 to 6 months, if he comes in intermediate or high risk, then we should consider him for lung transplant. So after 3 to 6 months, 3 to 6 months, like maximum 12 months. After 12th month, we will take patient for lung transplantation. Like if initially patient is coming in high risk, then we can directly consider referral for lung transplantation. So this is the like final chart.